All right, so this is a little bit the fun that I have in creating a conference like this, that I get to sort of challenge our faculty and challenge everybody to sort of make it exciting and interesting conference. And one of the things I highlighted was the concept that we as surgeons have, orthopedic trauma surgeons have two very significant powers, that of whether we fix something or whether we reduce something. And some of that challenge was to see perhaps if you only had one of those two powers, what might you do? And a few of the faculty were able to follow through in that challenge and really commit to one. Other times that was a little bit more challenging. And it certainly is challenging because it's not really what we do. We certainly use these two powers in conjunction to give us our end result. And hopefully our end result is to help our patients function better. These are my disclosures. Being an orthopedic trauma surgeon in San Diego, California, still busy, maybe a little bit too busy, but definitely the cases I'm doing, I'm having a lot of fun helping people recover and get better. Unite, which is also a co-sponsor of the conference, is our 501c3 foundation that helps support our contribution to this conference, as well as supporting our fellowship for training an orthopedic trauma fellow. And then lastly, my work as a surgeon coach through Surgeon Masters. And I don't think any of these will directly have impact on my presentation, but certainly the more you're aware of those, the more you might be able to decide that for yourself. A little bit of this presentation is definitely about my experience in my career and the challenges that we have in fixing and reducing any fracture. We become very skilled in the fixing part, where we can drill, we can place pins, all these sorts of things facilitate the fixation and that skill that we learn. But also there's an aspect of the reduction. And a lot of times we'll go through a surgical case and appreciate that we did one a whole lot better than the other, or that we were successful in both, or occasionally maybe less gratifying in both the fixation and the reduction. Sometimes that being related to our abilities as a surgeon, and sometimes that's the condition of the injury or the condition of the bone that we're trying to fix. So, you know, I've been involved in teaching and education for over 20 years, and definitely have fun creating these programs and bringing in such a great group of faculty to do this education for everybody. I think one of the challenges I have is really, how do you affect change? How do you help people improve? And what I discovered early in my career is that a lot of didactics and just spewing of knowledge was less effective and actually impacting the care that people then took back home and provided for their patients. And so that exploration of how a surgeon gets better or how someone improves has led me to a lot of the coaching concepts. And so I've definitely integrated a lot of those into the model of teaching and the questions that I ask people to help them get better. But I would ask this question is, you know, how do you think surgeons get better? So to the main theme, and to me, this is a lot of the challenges, because my hopes is that you got this in weekend one and you're getting this in this weekend and you'll get it in the third weekend. This decision making of whether the fix, you know, how we fix, whether the fix, how we reduce, whether to reduce, is impacted by so many factors. Sometimes it's a fracture that in my training, we would have been reading books and articles by Bob Buchholz saying that this did not have enough displacement to require operative treatment. And over the course of my career, the amount of displacement where we would then consider reduction in fixation has changed quite a bit. And so sometimes I think the decision on whether to fix or reduce is largely impacted by the amount of displacement. And here's one where it doesn't look too bad. I'm not going to show you the CT, but just as a little bit of a cycle of a technique that I still use some, but certainly spent a period of time where I was trying to get particularly good at a technique of reduction and showing a fracture being reduced and then ultimately fixed. And even here, you know, a few things that I can reflect back on in my experience in career was that I probably would have liked to narrow those condyles a little bit. I still think that a more aggressive, more formal open reduction, I think this one did include an arthrotomy, so I was actually visualizing this, but I would critique, you know, did I make that a whole lot better at that articular surface, because there's still a little bit of irregularity there. There's also a time in my career where I was tremendously criticized for not open reducing and fixing that medial side, but I've seen some people come around where this would be their ultimate reduction anyways, even after an open reduction and that medial side. But yes, this is potentially a strain, and you know, there'd be a lot of debate at this conference amongst our faculty as to whether some medial fixation would still be necessary. So again, still lots of room for us to learn and get better, even all throughout our career. And ultimate end result on that. Another one where, again, it spans a whole lot of different bones and fractures or injuries as to which ones need an operation and which don't. And here's another example of a fracture where is it really displaced enough to benefit from surgery? And so, you know, there are still some people that might look at this injury and say, well, where is the injury? What do I need to fix? But we can look at it and do a bunch of cuts through the CT. It looks a little worse. This actually happens to be a 42-year-old. So, you know, all these decisions of whether this needs to be reduced or fixed is definitely open to debate. Hopefully on Saturday, our crew that's going to be talking about calcaneus fractures can go into a little bit more detail of their opinion and how they might approach this currently. But, you know, the younger the patient, maybe this does require surgery, but we worry about some of the different things that are related to that surgical treatment. And most of my initial training would have been that this would be an extensile approach in everyone, but we've evolved even in this fracture care. And, you know, are you going to lay an incision on this for that? Well, again, I use this technique that I was dabbling in and using the balloon reduction and taking a fracture like that, and then using a tool that I found exceedingly effective in assisting with some aspects of reduction. And then you see there's other tools in there. I see, you know, I didn't start these techniques, I just learned from people. And, you know, some of the techniques that I was using then are techniques that are now being used extensively in other minimally invasive or less invasive techniques in taking care of calcaneus fractures. So lots of things in the fixation realm, lots of things in the reduction realm. Certainly advantages of our progress and learning in fracture care is in what we can accomplish in minimizing the trauma with some of these minimally invasive techniques, but again, still open to debate as to whether I have the power or we have the power to do these things in minimally invasive ways, or do they need to be in more formal open ways? And what are we learning in both of those? Then there's the fractures that are a lot more displaced. And the debate almost flips around where, okay, is it too busted up to fix? Is it too busted up to reduce? But again, we have tools and tricks that correlate with all those. And here's just a more complex fracture example. But why do we care? Again, it's because this is the conditions that we're dealt with, and we're trying to avoid ugly, angry things like this, or even worse, something like that. So why does it matter? It matters, you know, just because we have the power to fix or the power to reduce, where do our powers potentially create more harm? And so that's a aspect that I would describe as related to evidence-based medicine, but it's also a thing where that information is also contained within ourselves, because we also have to appreciate and understand what our powers are individually. And here's, again, another example of a more complex fracture being addressed by another surgeon and using these various principles. Here's an example using this technique of reduction and final fixation. Again, with some of these injuries, this potentially could be far better than those other complications, but each surgeon is going to have these skills at a different point. And then the injury, sometimes potentially because the reduction was not perfect, or the fixation was not perfect, or I don't even like that word, really good. The fixation wasn't really good, or the reduction wasn't really good. Then, you know, end result might be with arthritic or stiff, but still with avoiding other complications. Some injuries, again, I still consider I'm definitely more aggressive with some injuries where I'd likely be more aggressive and fix this differently. But sometimes minimally invasive and minimal fixation, because there's not much of a reduction to be done. Other injuries, there's a lot more to be done with both reduction and fixation. And so having a long list of tricks and pearls and ways to manage this is, again, a lot of the point of having this conference, so as many of us can learn these things as possible and learn from others. Other injuries, hard to say. I mean, I raised this point just because, again, when I started my career, if you got this close, if you got this aligned, and you got that as a end result of your surgical care, you had a length, alignment, rotation, you were going to get fracture healing and a very good outcome. And again, open to debate with a lot of the topics that we've been going over in our series. You know, we're seeing more and more people trying to get anatomic reductions of extra-articular fractures. And where does our power just be something that we're flexing a muscle versus where we're actually helping patients? And I don't have that for sure. I don't have all the answers, and even all our faculty may not, but certainly we can help each other get better at these things. And again, ultimately, to me, the point isn't just about healing a fracture and getting something that goes on and potentially avoids some post-traumatic changes, but what are we doing as far as restoring function? And I think these are, you know, where do our powers cause harm and complications, like I showed you earlier, and where do our powers cause good and function and range of motion and potentially elimination of pain. So in summary, these are questions I have. I actually was intending to share these with you one at a time, but I forgot to fix this slide. So, you know, the two powers, fix or reduce, question I would still pose to you, because I think it's an interesting thing to consider. If you only had one power, what would you choose? And then also, for this conference and for this weekend, hopefully you'll come here with the intention that tonight and through the rest of the weekend, what are ways to improve these powers? And obviously I have a little bit of a belief that we have more than these two powers, but what other powers do you have?